My name is Betty Rhodes, Councillor for North Ward in Wakefield and Chair of the Wakefield Overview and Scrutiny Committee. Supporting officer today is Andy Wood. Andy is the scrutiny officer for this particular committee, as well as joining us in other committees that we represent Wakefield on across West Yorkshire. As we go through the agenda for the input from our members today, I will ask you to introduce yourselves, and then hopefully the public can relay to their friends and families who said what at the meeting. And I do believe also, Andy, that we were expecting today to have Director of Education with us, Beate Wagner.
I'm here as an observer today, thank you.
Are you there, Beate? That's good. That's good. Welcome.
Thank you.
Welcome to the meeting.
Thank you.
All right, dear. With that, we'll actually go on to the agenda proper, and the usual Skype procedure will be in place. If you have a question, obviously, I think we're getting a little bit savvy on it now. Type a Q in the box, or if it's a comment, type a C. I will see your names come up and bring you up in order of your application to speak or ask a question. Item 1 on our agenda today is acceptance of apologies for absence. Andy?
Yes, Chair, we've got apologies from Councillor Clive Tennant, who's having internet problems at the moment with his provider, so he's unable to join us this afternoon. And apologies from Mrs. Mavis Harrison, our commission member.
Okay. Can I add to those apologies an email I've had from Councillor Martin Johnson? Martin may have some difficulties trying to connect this afternoon because of some noise elements near his home, but if the noise abated, he said he's going to try and join us. So we'll note that, and hopefully Martin can get some quiet time to join us today. Right, under the Chair's remarks today, obviously what I've done with this meeting in support with Andy is we have actually under item 8 give a written report on the activities and conversations we've had with various places during the last couple of months. And I will actually bring you up to date on any issues relevant to that as we go through item 8 on the agenda. Obviously as well today what I'd like to do is under my remarks, but again in reference to Mrs. Harrison, just advise the committee today. Mrs. Harrison, as you know, we always appreciate the contributions that Mavis has with her vast experience in health. And over a period of time, Mavis, as we lovingly call her, has always been a superb supporter and still is, and has always written in her questions and loved to write her questions at committee. Unfortunately, that's not been the case. And attempts have been made via her daughter's IT system to get Mavis connected. And unfortunately, that hasn't happened. So in order for Mavis to still feel and contribute a major part to our committee, as she always does, Mavis has written in several questions in relation to item 6 and the agenda. And I just wanted to let members know that we've accepted, even though it was late presentation of questions, we've accepted this and we'll deal with this in accordance with the report that comes up. If you'll agree that that's a way forward, can we move on then to the declarations of interest? Is that agreed? If it is, I'll take silence. Yes? Good. Hello, Olivia. I can see you joining the meeting. Right. Now that takes us on to the members' declaration of interest. If there are any, can you please inform the clerk to our meeting so they can be accommodated in terms of the governance of the committee. As we go along, as usual, members may find that any comments or queries that come up, if they want guidance on declaring any interest, please indicate at the time and we can make sure that you're covered in terms of the rules of procedure. That takes us nicely on to item 4. Any items of urgency? I have none. And item 5 today on your agenda is to approve as correct record the minutes of the last meeting on the 22nd of August, pages 1 to 6. Having looked at those minutes today, quite a lot of the issues on them are actually going to be dealt with under item 6. And if that's agreeable with the members today, unless there's anything of an urgent nature, and you agree that the items will be covered later on, please let me know and we can move on. I'll take your silence with it if you agree to that proposal. Thank you very much for that. I can see that I've got some messages coming in here. Simon, you're getting a bit of double back on echoing. Keep with it. And I've got one. Andy, you've got your video on. You're off. That's fine. That's fine. Okay. That then takes us nicely on to item 6 on our agenda today. And this is the Adult Social Care report on COVID response and future plans. It's page 7 to 31 on your report today. The emphasis on this report today obviously is well documented, and the report as it stands at the moment has given us the information of the last 6 months and how different services in partnering together have actually done a superb job in supporting one another in the partnership approach. And I believe at the same time sending the message out to the public of the way that the virus is actually dealing with the community as a whole and how we all need to be doubly protective. The major part of the report, and I don't want to deflect from anybody having a comment on the past 6 months, that's quite understandable because we all know in those 6 months the pressures that there's been. And I think if you want to go over that in a brief manner, I think the important thing when we go from the lessons to be learned from the past 6 months, Lisa and David, obviously then is looking forward. So with that, I'm going to hand it over to the appropriate lead. Who's that going to be, Lisa or Nicola?
I'm just going to kick off, Betty, if that's okay, and then pass it over to David, Lisa and Nicola. That's
fine. Thank you very much, dear.
Okay, thank you, Chair, and good afternoon, everyone. I hope you're all keeping safe and well. As you know, I'm Councillor Faith Heptonstall, the Portfolio Holder for Adults' Health and Wellbeing. We'd really like to thank you for inviting us here this afternoon to discuss adult social care's response to COVID, and particularly for giving us the opportunity to share with you with future plans, highlighting those challenges, opportunities and the risks that we face. We think that's really important. As you can see, there's lots to share with you. So as I say, I'm going to hand over to David, Lisa and Nicola, who will introduce themselves and then they'll move on to the presentation, if that's okay. Thank you, Chair.
Thank you, Faith.
Thank you very much, Councillor Heptonstall. I'm going to start off, if that's okay, and I think probably if we just introduce ourselves as we start to speak, that might be the best way. So I'm Nicola Esmond. I'm the new Service Director for Older Peoples and Physical Disabilities. Been in post about 6 or 7 weeks now, but previously I was Service Manager for Commissioning for Adult Social Care. So most of what I'm going to be talking around is around the care sector. You'll see it's a very long presentation. I'm going to try and do my best now to put that up on the screen for you. If somebody could just say yes when you see it.
Yes, yes, I can see it.
Oh, I've done a good job today now. I can go home. So yes, as Councillor Hepton-Stall says, thank you so much for inviting us to provide some assurance around what our response has been over the last 6 months of COVID, and to do a little bit of forward looking as to what we are going to do to get ourselves through the next 6 to 8 months and beyond. There are 3 of us. We're going to do a bit of a handover, so we're going to cover our own areas of expertise, but also give you hopefully a bit of variation in voices as we go along. These virtual meetings can be quite difficult, can't they, to keep your attention? And as Andy's briefing paper really accurately states, the last 6 months have been extraordinarily challenging for our district, in particular for adult social care, and that's our in-house services and our independent sector providers. Not to overstate it, we've just seen a whirlwind of such rapidly changing legislation and guidance, really impressively fast reactions and actions of health and care staff in changing what we do and how we do it to meet the demands that have been thrown our way. And then the context of the massive changes our society has seen, both as individuals and communities over the last few months. One of the things we're really aware of are the pressures this has put on people, not least our social care workforce who've been on the front line throughout, alongside our NHS colleagues and other key workers, often fearing for their own and their family safety, but doing what they can to keep our service users and their carers safe and well. And even to yesterday, I heard that one of the assistant managers of our own dementia care homes is talking about moving into the home to take care of the recent outbreak. So just to start off by saying the dedication and commitment of staff throughout has been outstanding. I haven't worked in adult social care for that long, but I've been really proud to be part of the Council's response over the last 6 months. So our presentation today is going to do a bit of scene setting, run you briefly through what we've been doing since March 2020, but focus mainly on what we're looking forward to. Because although the early weeks and months of the pandemic in the UK were really frightening and stressful, it was somehow a little bit easier to bear when the days were getting longer and warmer. The flowers were coming out. You could go and sit in your garden at the end of a stressful day. We all think that the coming months are going to be a very different story, with people's mental health struggling with the shorter days and colder weather, and just the ongoing stresses of having been dealing with the situation for 6 months and not really feeling like there's much of an end in sight. So we need to do a lot of thinking about how we mitigate some of those risks and challenges that we can see coming our way, and we'll cover that a bit later on. I won't go through this context slide in too much detail. I'm sure you're all really aware of the broader global context of the crisis, and have to say that most of the world seems to have developed into COVID vaccine circuit breaker antibody experts. Well, certainly that's what it looks like on social media anyway. But part of the context that we've provided is the handout of the statistics that we've sent with the pack. We thought it wouldn't be useful to go through all of those numbers, but they're there for you if you want to have a look at some of the data behind the presentation that we're giving today. In Wakefield, some numbers here, over 3,500 COVID cases, and sadly over 350, probably more now, COVID-related deaths. But in Wakefield, our levels of infection and deaths have been, over time, pretty much proportionate to our neighbouring authorities. In fact, we did keep our infection rates fairly low for quite a while, but as you know, they're increasing again. And as of today, I think they're about the same as Calderdale and Kirklees, slightly less than Leeds and Bradford. But one of the things I heard from a public health colleague this morning is that they are plateauing a little bit, and hopefully that'll be a similar pattern for us. Since we wrote the slides last week, our rates have gone up this morning to 239 per 100,000 in our population. And we've got, as of today, 101 confirmed and 21 suspected COVID cases in hospital. And Swift, our mental health provider, have also reported an outbreak of 8 COVID cases. 20 of our care homes have outbreaks as of yesterday, although most of those have been identified through the whole home testing, and they're really well contained. And finally, as I'm sure some of you know better than me, the odds are we're going to be in Tier 3 sooner rather than later in connection with our COVID alert levels. So we're just going to look quickly back through the last 6 months. This is where we're going to do some slide sharing. David's going to cover the hospital's wider partnership working. I'll talk a bit more about the independent sector response, and Lisa will talk through our in-house services and care management. We'll then run through the summary and lessons learned, and then we thought we'd stop at that point just for any questions before we continue to the looking forward. So over to David.
Thank you, Nicola. Good afternoon, everyone. My name is David Hamilton, and I'm an interim service director. My background is social care. I've probably worked in social care for about 36 years now, and I'm an ex-director of adult social care and communities. So I've been with Wakefield since March, probably a day before we went into lockdown, so perfect timing in terms of what we're doing. And part of my role is the liaison and link in with health partners. So hence my discussion with you around hospitals and partnership working generally. So just bearing in mind the Chair's comments at the beginning, I'll keep this brief in terms of the last 6 months, and I'll just highlight a number of key issues and things that I think we've probably learned that affected us over the last 6 months. So obviously significant pressures in hospitals, and our role was clearly to help and support the hospitals, and in particular making sure that we had safe and timely discharges from hospital into various settings. Ideally home, but clearly that isn't always possible. So a lot of people went into residential care homes. One of the issues for us is certainly around understanding at that point in time what the potential infection rate would be, therefore what would be the demand on adult social care, both in terms of bed-based services and community-based services as well. So despite our best kind of predictions and modelling around this, it was difficult to try and preempt that with any real accuracy. And as we know, it isn't a science, it's difficult to do that. But we did struggle with that across health and social care in terms of understanding those figures in the early days. And clearly you will recall at that stage there were lots of issues around personal protective equipment and difficulty interpreting the range of national guidance that came out almost daily at that point, and helping partners, in particular in the independent sector, understand and understand the implications for them in terms of that guidance. So a lot of effort was spent around those two areas. And clearly we all focused on COVID cases, which meant there's lots of cancellation, particularly in the hospitals, around non-urgent activity. So a lot of the elective activity around operations, etc., and screening and testing was put on hold because we're all expecting a massive influx of COVID cases. Equally in adult social care, day services in particular, we closed down because, again, people didn't want to do that, and there was certain risks associated with that as well. So the real pressures around at that time were certainly around the discharge and the demand around that. Fortunately, I think we had some really good working relationships with health in any case and some good processes, so that helped, with lessons learned that we'll come on to later on in terms of how we're doing that differently now. And then at the end of probably end of May, June sometime, I was asked to lead on a review across the wider partnership, which was called Stabilisation and Reset, which was really looking at lessons learned over the past 3 or 4 months in relation to COVID. And again, they'll come out later on in terms of those lessons learned, some of the challenges and some of the risks. So with that, I probably hand back to Nicola.
Thank you, David. So in the independent care sector back in March, this slide summarises the main aims that we realised that we had to achieve. So protect our citizens, protect our frontline care sector staff, and sustain the care market. We didn't know what we were heading into. We knew that there was going to be a struggle, and we also wanted to make sure that after the intensity of the early days had died down, that we still had a care market, that they hadn't all gone under. So quite a lot of pressure really to think about what was the right thing to do. So we set off with some scenario planning alongside providers to work with them to understand what they thought the problems were going to be and what we could do together. I ran 3 sessions, one with care homes, one with dom care, and one with supported living. And they were on the premise that all our business continuity plans were not going to be good enough. We had to think outside the box with what we were facing. And together we came up with some really sensible things that basically we just started to implement from then onwards, and it included things like the reshaping of my commissioning team to be a coordination hub for information, support and guidance for the sector, and that covered adults, the independent sector, like our in-house services, as well as outside children's and CCG providers, because we thought there's no point doing it multiple times. We'll do it for everybody. We had a phone line and an email address, so people could ring us up and contact us. We gave daily briefings, helped interpret the guidance, coordinated risk planning, so providers told us who and why their most at risk service users were, and we put in plans to support. And we started weekly conference calls at first, then turned into Teams meetings with care providers that are still running and are really popular and useful. PPE, massive problem. So initially we acted as a central hub for distributing, and then other local authorities took over, and we just managed the processes to manage the demand. But thousands of items of PPE the council has given out to care providers and individuals who are looking after loved ones and needed the PPE. The point about financial sustainability. We put our own measures in place early on, just increased rates, for example, for the care homes to cover the increased costs they were having with PPE, where the cost of a mask was doubling or tripling or even more sometimes. Paying domiciliary care and supported living on a percentage of commissioned hours rather than on actual, and that was also supported by the Infection Control Fund that you may have heard of from the government, where they put £3.5 million into Wakefield care sector in, I think it was around October time. No, it was earlier than that, August. And then another 3 million's just been given to us to give out around infection control measures. So financially, I think we've done quite well in supporting the sector. Other things we put in were quite a lot of work with health colleagues around the wraparound support that they needed for things like end of life. A lot of their residents sadly were dying or at end of life, and helping with access to medications, access to the professionals that they needed. A huge program to put in infection prevention and control training and daily support by phone, and also just crisis support. So one of the most horrible weekends of my life was over Easter, where it seemed to be crisis point in care homes, and just about every time I answered my phone it was another care manager almost in tears, often, well, not often, once at least, suffering from COVID herself and refusing to go home. Because she had to find the staff to look after the residents. It was extraordinarily stressful. On testing, we now have really robust testing in care homes, but we didn't then. And Wakefield was one of the first areas to put in testing opportunities for care sector staff when most of the country was just for the NHS. And later on, we supported when the testing systems started to fall down, if you remember, a month or so ago, with offering local routes through Connexus, which is our local testing body. All of this has led to really good relationships with the sector, actually, because the majority did feel we were going above and beyond to understand their situation and support them as much as we could. And I've just got a little quote from a letter they wrote to the council in May, which I thought you might like to hear. They said, Wakefield Council has been at the forefront of each change and challenge, and we've received information so efficiently that we've been able to respond to challenges and problems that care homes in other parts of the country have not been so quick to do the same. We feel that this fact has helped our area to keep cases and deaths lower than they could have been, and certainly lower than in other areas of the country and in neighbouring authorities. And this is from our independent sector liaison group, who are often quite challenging. So that was really good to see. Overall, about a third of our care homes were badly hit by COVID and lost a number of residents. One of our larger dementia nursing homes lost about 2/3 of their residents very early on, and we've had about 145 COVID registered deaths in our homes. And unfortunately, that's left some care homes financially at risk, so we know there's a lot more we need to do. For domiciliary care and supported living weren't as badly affected, touch wood. In fact, because we paid them more generously, they actually were very happy with us. And our waiting list for domiciliary care, which in February this year was around 80 people waiting for nearly 1,000 hours of care, dropped right down to almost nothing, so 5 people at the lowest point in April. Although now that we've reverted to our usual ways of paying, that's increased again, and we've now got about 60 people waiting for care packages. And also we've been helping care homes negotiate that tricky issue of visits from relatives and friends, which is that frightening balance of infection control and people's health and well-being, and recognising that digital solutions aren't right for everybody. So, Lisa.
Hello. So some of you will know me. I'm Lisa Wilcox. I'm now the Service Director for Learning Disabilities and Mental Health in Adult Social Care. So I'll just take you through a few slides and some of the lessons learnt. So in terms of the in-house services, a lot of the challenges we were facing with our in-house services, provision services, were very similar to those in the independent sector. The same issues around availability of staffing, the constantly changing government guidance, and the use of and changes to PPE, as well as the supply of PPE. And there was tensions between health and adult social care at points having slightly different PPE requirements, and that the level of anxiety or lack of safety that gave to our staff that we had to manage. As Nicola's mentioned, one of the key problems and issues we had with residential care was managing families' natural desire to see their loved ones, with that trying to maintain a situation where they were reducing the risk of transmission. Our reablement and extra care were critical to kind of making sure that we maintain people in their own home, often bridging gaps between providers when people coming out of hospital and others providers started. Our shared lives carers, who are the people in the community who take people with learning disabilities or other needs into their own homes and treat them as part of their family whilst giving them support. Those carers did an incredible job, particularly when lockdown first started, because they had the support networks that they might normally have used to help them manage the situations were no longer there, and they were having to manage both their own anxieties but also the anxiety of those people living with them about what lockdown meant, why they couldn't see other people, why they couldn't go perhaps to their day opportunities of other things that they might have done. And we managed to put some financial support around that to sort of recognise that additional work they were doing. Our day opportunities we closed to start with, but then we've managed to safely reopening those now, and they're not fully back up to capacity because we need to maintain social distancing and make sure people are kept safe, and we don't want service users with learning disabilities to go back to their families who are often elderly themselves and take an increased risk of transmission. I suppose one of the things I'll just note is that we're talking a lot about the past 6 months, but it's left us in a much better position in some ways to go forward. We've learned a lot of lessons. We've found new ways of doing things, and we can see some pressure points. That's not to say it'll be easy going forward, anything but. And I think a lot of our staff are quite tired, and people are understandably feeling concerned about the ongoing levels of restrictions. But we have learnt so much, as I'll go on to explain in a moment. And we've also worked hard on our equipment and wheelchair delivery services to make sure that they continue to be delivering, and not only delivering but also managing the increased demand, because the pressures of getting people out of hospital. If you can just thank you, Nicola. So then, in terms of the care management work that we're doing on our social workers, obviously quite often social workers would normally go out to somebody's house and visit somebody to undertake the assessments, and we were restricting that to purely essential visits. We didn't want to put our workers, or more importantly the vulnerable people they were assessing, at risk. So we've had a lot of increased use of technology, and we've had to be creative at times. Not everybody has access to technology. Our social workers have learned a lot around using WhatsApp chats and Teams and Skype, as well as also doing conference telephone calls so they can have carers and relatives on the phone at the same time to have an informed conversation. We've also had to move our social work staff support to be longer core hours, so rather than the usual 8:30 till 5, they've been working 8 while 8, not just Monday to Friday but 7 days a week, to make sure we're trying to support those hospital discharges that were so important, to make sure that we're protecting the NHS and having the capacity there. We've had to change to think about how we support our workforce working remotely. those social workers, both in mental health, older people, learning disabilities, have been doing some really complex and demanding work, but often from their own homes, and trying to manage the responsibilities of emotionally charged conversations, whilst also dealing with childcare at the same time and trying to maintain confidentiality. So we've been giving a lot of support to people juggling those challenges and the impact that has on their own well-being. Initially, demand went down for our services, but that has picked back up again, and we've been, if anything, doing extra work now as well, trying to make sure we manage the impact that we know that there is around people's mental health and well-being, the impact on people learning disabilities and their families from having the day opportunities closed and their respite opportunities reduced, and carers who have been doing so much more to support people at a time when sometimes they're worried about letting services through their front doors because of the risk of transmission. We've also been doing some work cross-council, working with our colleagues in communities to support those people as shielding as well. So we've talked a lot about the past 6 months, and as I said, a lot has happened, but we've learnt a lot. It's been a really rapid period of adjustment. There's been constantly changing government guidance, and it's meant that we've had to increase our knowledge and ways of working and think about different things like using PPE, which social workers might not have done before. Our care workers often weren't using masks before. So it's been a big change. The finances has always been an issue in the background. What we've found is that we've spent less on residential care because, unfortunately, there's been a large hit on those people living in residential care because they're elderly and frail and very much at risk of COVID. Equally, people have been much more reluctant to place their loved ones in residential care because of those perceived risks. But we have had an increase in take-up and expenditure on domiciliary care. So it's been important for us to understand that. As Nicola's noted, we've had real improved relationships with the care sector, and we've got much more responsive, faster and more agile working, which will place us in a better place going forward, hopefully. And what we've really learned is that communication and engagement are absolutely vital. So there's all those challenges we've dealt with, the technology that I've touched on a little bit. We've had to get much quicker at our decision making. It's a fast-moving pace of work that we've been dealing with, and we've got better systems and processes in place now, I think, to try and make sure we can respond very quickly, and that again will set us up going forward. We've got really good partnership working, and we've done a lot of upskilling of our staff and more flexibility. So one of the things we recognise, particularly with our staff, is that we're often needing people to support the hands-on care provision. And one of the difficulties we had was that we might have social workers who are willing to work in a care home, but if they had ever done the moving and handling training, it was significantly out of date, and we didn't want someone untrained to be helping somebody move from their bed to a chair using a piece of equipment like a hoist without the proper training. What we've done is we've made sure that we have identified staff who we might be able to pull into work in different ways, and to make sure we've already given that necessary training around first aid, around moving and handling. So if we need to use them very flexibly, we've got that opportunity, and they're already trained up, ready to move when we need them. We've absolutely been working across the sector, looking with our independent partners around how we can make sure we've got that right support for the care homes, and how we can continue that going forward. Similarly, we recognise that some of the early days meant that people stopped what they were doing to focus on COVID, both within ourselves in terms of pausing our day opportunities to try and manage some of the risks that were there, but that also gave us those day opportunity staff to move across to other areas where we were short of staff, and to provide that provision services. What we're recognising going forward is that worked really well, but those day opportunity staff are now back at work providing day opportunities. The hospitals paused a lot of elective surgery, and they're now trying to catch up with some of those necessary situations. So that balance now between business and usual and what we need to face going forward, going into winter and COVID, is really critical. And it's a whole systems approach to get that right. And it's really right that we get communications right, so everybody knows what's happening, when and how. I think we have absolutely been pushed into improving our creativity and innovation. And we have to really recognise, and we have done, the impact it has on our staff and our provider staff outside in the communities. It has been a very tough 6 months, And we're mindful that if there was a bit of respite in summer, we didn't possibly take full advantage of it because we're going straight back into winter and COVID now. And we're really mindful that our staff they've been working above and beyond for a long period of time, and we need to make sure we keep them to keep that maintaining that positivity and the work that they're doing. And then last slide for me, so for any questions, just to reiterate that around the communication working together, and we've had a number of additional issues around safeguarding care homes, perhaps because of a lack of footfall of going through and seeing what's happening. We've been working ever so closely with our safeguarding teams and CQC to try and manage some of that and to improve that. But I'll leave that there and see if anyone's got any questions on those first 6 months we've been through.
Okay, I'm conscious of the time, and I really do want us to spend a lot of time on going forward, bearing in mind the circumstances that prevail at the moment as well. And I think it's incumbent on us all to say how much we appreciate what the staff have done to cope in that last 6 months that they were through. Any questions from any members of the committee? Any comment on this last 6 months and the learning out of it?
Sorry, I've got a question and comment, please.
Just put a Q in the box, or if you need, let me know, Nicola.
I have. Can you not see it? No.
No.
Yes, and I have before that.
No.
Oh. Right, okay.
It's coming through now. Things are a little bit slow. Right, I've got you, Nicola, and then Olivia. Okay. You got a question, Nicola? Yeah.
Just 1 second. The tablet battery's about to die. Yes. So first of all, just well done to the team for such a difficult 6 months. It's incredible what you've done and achieved in that time. I do have a couple of questions relating to care homes and other non-COVID deaths and things like that. I've got one of the care homes in my ward has had no cases whatsoever, but they're not allowing any visitors. And so I've had a relative contact me regarding the mum who her husband died in February, so she's grieving, and she's not been able to see her family since March. They can't FaceTime or anything like that because she just paused at the screen, and it's just too heartbreaking for everybody concerned. So I suppose, is there any way we can have I just feel that the mental health impact is now worse than the threat of the virus. I've dealt with on a daily basis calls from people who are just struggling so hard with lockdown and all the procedures. I know of 2 people in the past week who've committed suicide due to not being able to cope with the lockdown, and I'm just absolutely terrified that if we go into the next tier, that is going to be even greater. It's heartbreaking that our grandmas and granddads and mums and dads can't even, in care homes, can't even hug their kids, and just the whole mental health impact is just so great. I just feel that we need to do something and just say stop. Okay, there are other things that are worse than this virus, and it's the mental health aspect that's worse. Sorry, I just needed to say that because it's, I'm heartbroken hearing about the
Thank you, Nick. First question obviously is, can somebody go into a home that has no COVID residents? Well, I would think, and I'll hand it over to you, I would think the same applies as in level 2 we're in the moment, that nobody can go into anybody else's house either.
Yeah.
And the issue to do with the mental health issue, I think we're all aware of that, Nick, and the questions that are being asked in terms of, as Lisa has said, of people working together as much as they can through the remote situation that we all find ourselves in. Lisa, do you want to answer the issue about the mental illness approach and how you're trying to deal with that and cope with it with people in the community?
I will do. I'll also touch on the difficulty around visiting in care homes, and we acknowledge, how difficult it is. Now we're in Tier 2, the government guidance says that there should be no visiting in care homes apart from exceptional circumstances. We've just been working flat out this week with our legal colleagues and liaising with other people in West Yorkshire local authorities to try and create a consistent guidance around visiting in care homes, which, as I speak almost, I think there's a community call with our independent sector care home colleagues where we're explaining the guidance. And what we've done is we've provided some guidance which talks not about what is an exceptional circumstance, but about the importance of looking at each case individually and what the impact is, and balancing the risk of transmission of COVID, which is likely to have a very significant detrimental effect on anyone in a care home who catches it, against perhaps the mental well-being, where people are feeling isolated, their mental health is deteriorating, their ability perhaps to take in food and fluids, which also provides a real risk to themselves. So that it's very much down to the care home's manager's discretion, but to balance up on a risk-based situation whether or not it's safe to let somebody in, or whether or not there can perhaps be a visit through a window or through some other technology. So there's a range of options, and we've produced some guidance, which I'll be honest, we have worked closely with our colleagues in Leeds and based it on some work they've already done, collective sharing and working there, but to try and really recognise that, because I think it is very distressing both for families but also the loved ones in the care homes where they're not able to have that contact that they're used to. So it's something we recognise. In terms of the wider community, we've worked to try and commission some helplines so that people have opportunities to try and access greater support, and the Samaritans have got a new sort of check-in kind of service to try and give some more general support to people, because we do recognise the real impact of people in the isolation and loneliness, and we're working hard to try and make sure we promote those opportunities, because we really recognise how difficult it is for people. I hope that gives a little bit of reassurance, but we do recognise it's a very difficult balance that we're having to strike in terms of the restrictions we're facing and how we can support people.
Okay, Lisa, do forgive me interrupting, but we're tending now to go into issues that's going forward as well as while we're trying to cope with the situation you've had for the past 6 months. I hope that's all right, Nick, but these are the rules that have been laid down under the different levels from government, and we all have the same concerns about people suffering the mental illness, and I think that the work that's going on between them is really to be applauded to help everybody. Olivia, you've asked a question, and Nicola, you've answered it in terms of the allocation of resources there. Can we keep these questions so that they're coming in the boxes and we can keep them in order, please? Olivia, are you happy with the answer you've got from Nicola?
Yes, I am. Although Nick did influence me to ask a further question about, it's really difficult anyway in residential homes, but what's the situation with chiropodists and dentists and physiotherapists going in? I mean, it's one thing to try and keep people safe, but if they need additional support, in normal times it's really hard to get things like dentists into homes.
Shall I just pick that up? I think you're absolutely right.
You can pick that up as what the practice was in the past and have the lessons learned and how you can do it better in the future. I think we can deal with the future under the issues, but Olivia's brought up a very valid point in terms of the overall packages of care for individuals. Did you have problems in the past, and were you able to sort them out in terms of the needs of the residents?
There have been problems in the past. Obviously, when there was lockdown, there was nobody going into care homes, so none of that happened. And then we ended up with a situation where we weren't supposed to have professionals visiting multiple care homes, which obviously chiropodists and such like did. So from what I've seen from a couple of examples, there's just been an awful lot of toing and froing and delays. And so that I think a lot of people haven't had the care that perhaps they would have wanted. I guess that's the past, Councillor Rhodes. What we do going forward, I guess we can pick that up in the next half.
That'd be great. I'm conscious if we can keep to questions that are succinct and answers as well, because the next phase of it is so important, bearing in mind the situation we're in at the moment. Andy, our officer, you wanted to come in regarding safeguarding, and then after you is Gillian. Andy?
Yes, Chair, very briefly, just to inform committee that safeguarding will be on the agenda at the next meeting on the 3rd of December, so members will have the opportunity to consider that, particularly in care homes. And additionally, we'll also be looking at mental health and response to COVID-19, including system resilience, access and wellbeing services. So that will give the opportunity again for members to raise those salient points at that particular meeting.
Thanks, Andy. Gillian, you have a question?
Chair, that's fine. Mine was regards care home and safeguarding. So I'm satisfied with the answers that I've heard so far. So my question can wait until next month. Can I just say though that it's fantastic to hear how you've all adapted to the situation with COVID, and it's so encouraging. I'd like to say well done for all the work that you've been doing. I think it's absolutely superb.
Thank you, Gillian. I'm sure that'll be passed on to all the staff. I just have picked up in the report that you sent a couple of things, really. You sent the separate information report, including all the issues. That was the data statistics, and I know members have been sent that as well. You mentioned domiciliary care. This report came to us just, I believe it was beginning of the week, or certainly no more than last Friday of last week. And it says here in this report on domiciliary care on bullet point 4 that there are 491 hours of care on the waiting list. But that's a different figure than you presented to us today in terms of how you coped with the reduction. So what happened in less than a week that you're now saying there was only about 6 or 7 waiting, but yet this report is telling us there's 491 hours. I'll follow that through by the query asking, is that as a result, if I'm going on 491 hours, is that as a result of people waiting for an assessment of their needs and then the financial package being put in place to support them? Or is it that you've just had an increase overall in terms of need? And if it is on a waiting list, have we got the capacity for care packages for individuals to actually provide the care? Because I am aware that there are some companies, smaller ones as well, who provide such care, who feel very anxious in case any of these care packages have not been tested for the COVID virus, or indeed maybe have been discharged from hospital with it as a way of emptying beds.
Thank you, Councillor Rhodes, and apologies for not being clear. The difference between the hours of care in the statistics and the number I said in the presentation was versus hours and people. So there are around 5 people who need a number of obviously more hours of care. So that's the difference there. It will have changed from last week, definitely, but that might be the reason why it looks so different. Generally, people are on the waiting list, possibly for some of the reasons you mentioned, but more often I hear because they are geographically difficult to fit into a care home round, if that makes sense. If they are in the farther reaches the district, and actually most care providers can't incorporate them easily into an existing round for their staff. Or sometimes it might be the timings. So obviously morning get-ups are quite popular and might be more difficult to fill. So it's generally reasons around the individuality of that care package that makes it problematic. Capacity, we think we've got enough. It's really difficult to tell. I mean, we have lost a couple of providers. I was going to pick that up a bit later on, but we've managed to pick up all their care packages within our other providers. But it's definitely something we're aware of and concerned about. broadly speaking, we're hopeful that we'll be okay, because recruitment of staff is something that they always have a problem with, and actually there are more people around looking for jobs. Anyway, there's lots of reasons why we are hopeful that capacity will not be as much of a problem as it could be, but we are having to keep just on top of it, Councillor Rhodes, I'm afraid.
Well, that's kind, very informative, Nicola. And before we go off on that, because what happens in the past is very relative to the future, and the next question is, what are the regulations and rules about care home staff working in more than one residential unit?
It absolutely shouldn't be happening, and that's why the government's given £6.5 million to the sector to try and prevent some of that, because it's been identified as one of the key infection risks for care homes.
Okay, and how does that relate in the past 6 months and going forward in the future to packages of care that are delivered under the direct payment system to individuals who may be discharged back to their own home, because we have to accommodate both the residential sector when beds are being reduced, and we have to accommodate those people who can go back home but with a package of support care. What figures do you have on any of those, Nicola?
Is this a question in relation to staff sharing?
Yes. Well, packages and staff, how are you coping with both? I mean, yeah. I understand about the care homes. We've all had a concern about that. But what about the smaller packages that are out there, people discharged into their own homes?
They seem to be managing really well, and the care sector seems to be picking those up well. What I am, again, I'm going to mention it again in the future, uncovering is that some of our domiciliary care providers are reluctant to provide care for COVID positive. So that's something we're going to need to. Yes,
we're coming on to that. We're coming on to the next.
If I could just possibly chip in terms of the people who've got personal budgets and are employing their own PAs. We've been supporting those as well, and in fact a number of people have increased that because they feel more confident with having friends or family providing their support, who they know, who they are, where they've been and what's been happening, rather than have other care providers. So that's a slight shift that we've had over the past 6 months to support people in their own homes.
Forgive me, Lisa, interjecting. I thought under the direct payments you couldn't employ a member of your own family.
You can't employ a member of your own family who lives in your own home. But if you have a sister or a brother who's in another property, then you are unable to use them as a PA.
Okay, that clarifies that then. Thank you very much, Lisa. Right, and of course you did pick up on the other points that I'd marked out in it as well, was the reduced adult social care spend in residential care, but an increase in domiciliary. You mentioned the obvious reason, because people were so scared of wanting to go into residential homes. But now we're looking forward and your plans for the future. I'm conscious of time, and if we could actually, just deal with the presentation we've got forward on salient points, and then we can hand it over for our committee members, because I'm sure we're all conscious now of different changes again. And now we're looking forward. Who's going to deal with this for us? Is that you, Lisa?
That's me, Chair. So if I can start again, we'll do a bit of a tag team on this as well. So looking forward, the kind of 4 sections to this. One is just a general overview of it. Then some of our priorities, which are certainly around protecting delivery in the care sector, protecting the most vulnerable in our communities, and then supporting NHS and in particular hospitals. So that's what we'll cover in this next section. Next slide. So generally, I think people over the summer felt that actually once we got over the main spike in April time and the COVID incidences came down quite a bit, there was a bit of a respite for some people, but I think we have to acknowledge that a lot of people were still working flat out to do that and dealing with the aftermath of some of that. So certainly frontline services, IPC colleagues, public health, operational services were still working flat out to do that. Whilst in some hospitals actually quietened down and there was a bit of a respite for some people. But I think we need to recognise that some people didn't get that respite, and just it's been constant since then. So we're starting now to see an increase again, as Nicola said earlier, in the numbers of COVID positive patients in hospitals, and in particular the number of elderly people who are starting to become infected and therefore presenting at hospital as well. An interesting comment from hospital colleagues recently is that in the emergency department, whilst it's very busy, they are seeing an increase in COVID positive people or suspected COVID positive people at that stage coming in. And they are seeing an increase in the number of admissions. So they're seeing a kind of 50% of those people are admitted, whereas in the past that percentage wasn't as high. So people are going in there. And equally, the length of stay, so the length of time that people are spending in hospital, is around 50 days now. So that's much higher than it was previously. And part of the reason for that, people think, is because the treatment is better than it was back in kind of April, May time. So people are hopefully recovering, but it takes them longer. So therefore, they're staying longer in hospitals. So some interesting stuff happening around the hospitals at the moment. And equally, we're now just starting to understand and see some of the impact around long COVID, which I'm sure members have picked up now, particularly through the media. And there's lots of research being carried out about some of the longer term impacts of people who have contracted COVID in the past. And we're still learning about that in terms of what that might be. So there will be a legacy from this, we're sure, in terms of the impact on people's health and well-being going forward for some time to come, we suspect. And equally, looking forward and in planning, because we knew this second wave was coming and was anticipated, there's clearly, as you'd expect, been lots of joint partnership working and planning around this. And nationally, there's been a number of what they call stress testing of our plans. So we had a series of events where the military coordinated and facilitated some events where they were testing our plans and challenging us, and we were challenging each other internally to make sure that our plans were as robust as they could be, thinking ahead in terms of the second wave coming, etc. So we had a national event on that. We had a regional one across partnerships, and indeed we had one across the council, just looking at the corporate response and council hall response to particular scenarios that we can anticipate going forward. So I think that's been really helpful in testing that, I think, giving us a bit more confidence, I think, in terms of our planning for this next 6 months in particular. And again, increasing partnership meetings. So over the summer, some of those intensive meetings were stood down. So we were having almost daily meetings, sometimes with health colleagues in particular, but other partners as well. We're now starting to ramp them back up because I think the second wave has come sooner than most of us predicted and wanted in particular. So I think we're in the middle of it now. So we've now stepped up those meetings. So, for example, with health colleagues, we're meeting twice daily, just to look at those discharges and numbers of people who are in hospitals, etc. So we've increased that partnership working, and emergency planning measures are being reinstated as well. Equally, we are recommissioning some additional capacity again in the care sector to make sure that we are as prepared as we can be for the surge coming out of hospitals. We know through experience that when hospitals get very busy, it's about perhaps a week later that we get very busy as well. So we know that we are ramping up for that, and we are also commissioning that capacity. And we'll say a bit more about designated care settings a bit later on in the presentation as well. And staffing is a key issue for us, which we'll touch on in terms of risks and challenges. But we are building capacity in our teams to cope with that, what we know will be additional demand that is coming. So, for example, we've had a number of people who are on temporary contracts, and we've taken the decision to extend them till the end of March to make sure that we are strengthening the teams as much as we can, because we know people will be absent for lots of COVID-related reasons in the near future, and indeed part of that's coming through now. So I'll hand back to Nicola for the next slide, please.
Thank you. Can I just check you can hear me, because I can't see my screen now that I'm presenting?
Yes, we can hear you, Nicola.
Lovely, thank you. So this is about protecting delivery in the care sector, and building on what I described in the first part of our presentation, I think we would say that we would hope we're in a fairly good place with the care sector, because we've set up the procedures, the contingencies. We've learned a lot over the last few months, and relationships have been really positive. We've been talking almost constantly with our independent care providers. As far as the safety and well-being of residents, I think one of the most tricky things is going to be the visiting issue that has already been picked up by members. Absolutely, it's a shocking decision to make, and a very difficult balance to tread. There's been things like free iPads being given out to care homes from centrally, and obviously they've been allowed to use the infection control funds to help with safe visiting. But some of the care homes, particularly some of the national ones who maybe have less control over their individual homes, are led by what the national directive is around that. So that's also sort of tying some people's hands. And obviously digital isn't a solution for everybody. So I think one of the things we're going to need to be doing over the coming months is working carefully with our care sector colleagues to try and help them tread that balance of visiting and mental health versus infection control. And obviously their fears are not just the spread of COVID, and actually I think some of the homes who haven't had it at all are more fearful than the ones who have, which is maybe understandable, but help them understand how we can do it better together. So PPE, obviously not the thing it was a few months ago. We've generally got lots of stockpiles of PPE now. The main challenge now is trying to ensure that staff stick to robust practice. It's really hard to do in, day out, changing of masks and all the rest of it. So we're supporting the sector by trying to keep on top of regular training, regular reminders, working with our infection prevention control team colleagues, and the Care Quality Commission are also doing infection control focused inspections, just to try and keep on top of that. And as we can see, the outbreaks are happening, but they are being contained. So on the whole, I think that's probably okay, but it's definitely going to be something we need to keep an eye on throughout the coming months. Testing's now in place, and hopefully some of the problems that we saw are starting to be ironed out. And although it's difficult to do containment and management of outbreaks, it's a million times better than where we were in April, when actually we had no idea if people were infectious and they were still coming into homes. So as long as we can maintain the robustness of the testing and ideally get results more quickly, because often that can cause problems with staffing, that should be a good thing for the coming months. Financial sustainability, as I mentioned, that infection control grant has been really helpful, although it has been a bit restrictive on what the homes can spend it on. I think they have actually found ways to spend it. We've done a lot as a local authority to support our care sector over the last 6 months, but we've stopped our blanket support, and we're now taking a more targeted approach. So we did a financial sustainability survey back in August, where we asked care homes to tell us how they were, what they were doing, what the cash flow was like, what their greatest concerns were. And so we've got some data and information there. We've also got our understanding of those homes who have a high number of vacancies that they've not been able to fill, and therefore their cash flow situation is at risk. So we've got a much better idea of who we need to help as much as we can over the next 6 months. So the idea has been we have a hardship fund, a hardship approach, really, because some of it might be loans, not just grants, depending on the situation. So that's what we're going to do around the financial support. We do know this is important because even just in the last month, one of our nursing homes has deregistered its nursing beds because they weren't financially sustainable. And nursing beds in our district are not ones we want to lose. So we need to keep an eye on that trend, definitely. Staffing is going to be a problem for absolutely everybody. But in theory, we have mechanisms in place, both internally in the council and with partners, to support when needed. And we're just going to have to see how robust those are. They managed to sustain us through the early COVID. So with luck, we will manage. But we just do know there's going to be a problem with staff being tired and maybe being resistant about going that extra mile when they feel they've been doing that for a long time. Balancing that with, we do know there are more people around looking for jobs. And maybe that might help with the situation. Just to touch on the system working and the bed base to support the hospitals. We've also within the care home sector been commissioning beds, as David mentioned. We have a COVID positive unit now at Snydale Care Home in Normanton. I think that's now up and running, or it will be next week, where we can discharge people who are COVID positive from hospital into that unit for a self-isolation. period of time before they go back to their own care home. And we're also looking at designated settings in other care homes. So actually, if people could go back to their own home, that would be much better than them going from hospital to Snydale, then back to their home, because it's very disruptive for them. We were also looking at resilience on a much more permanent basis than the winter planning that we have done in the past. So we are also commissioning a model of care home beds throughout the year, which is going out to procurement very shortly. This is to try and avoid that kind of inefficiency of ramping up and ramping down that we have sometimes when we commission this kind of solution. And also recognising that as far as hospitals are concerned, winter is all year as far as pressure is concerned. So actually, we probably could do with a more robust, ongoing solution for that. And one of the exciting things that we are going out to procure is a specific dementia unit. So we have terrible outcomes for some people who are stuck in hospital for a long time with challenging behaviours, which might be as a result of them being in a hospital environment, and they would calm down if they were able to be looked after in a more homely setting. But we have difficulty finding somewhere to take them because of the challenging behaviours. It's been a bit of a no-win situation. So we are commissioning a unit which is going to have wraparound support from Swift and from medicines optimization, so that hopefully we'll have a quick solution to look after those people, stabilise them, figure out what it is they need going forward, and make sure that we can provide it for them. In domiciliary care, we've mentioned waiting list and capacity. We have lost 2 providers, I mentioned, since we stopped paying on percentage of commissioned. Luckily, they weren't very large providers, and we've managed to pick up their work within the other providers. But again, that's something to keep an eye on. We've gone out and asked all our other providers how stable they are, and they've all been quite positive about that response. So fingers crossed. Community spread is now more prevalent, so there is a risk with providers who haven't been used to supporting COVID positive individuals. I don't think many of our providers have done that actually so far. So we recognise there will be issues there. We've had those conversations with providers, and most of them are seeming to be able to put things in place to cover COVID positive service users if needed. However, some have categorically said no, they would not provide care for people who are COVID positive. So that's going to be something we need to look at, how we mitigate the risks in that situation. For supported living, the challenges there have mostly been around people understanding the need for PPE, finding it quite distressing and frightening when people are wearing masks, not able to get out as they used to. The changes that they're having to accommodate in their daily life, which is not something that they find very easy sometimes, but also that some families are under some significant strain without the support that they've normally been used to, like the daycare or maybe the respite cover that they used to have. So just in summary, we are continuing with all the measures that I mentioned in the first part of the presentation. The support and guidance hub is ongoing. There's a lot of work wrapping around the enhanced health and care homes with our health colleagues. There's digital consultations now with hospitals and GPs into care homes. District nurses and therapists are still going in. So we're doing as much as we can to make sure that we're keeping the residents healthy and well as well. And just while continuing to try and work in partnership with the care sector and our colleagues to be as responsive as possible.
Okay, thank you, Nicola. We are going to have to move on with let's comment on every bullet point until it's coordinated together, because we have pages left here that have issues that I'm sure members want to discuss. And we have other items on the agenda. I don't want to curtail, but at the same time, a lengthy presentation like this, justified as it is, means that the members have to have time to comment as well and ask questions. The next page is looking forward, protecting the most vulnerable. Now, the bullet points on that gives us an indication of all the issues that you've previously worked with in terms of the partnership working, which we would expect anyway. And from your conversation up to press, this actually seems to be working well between all the various agencies. come in and as I'm on this to give us some time, do interject if you need to. The community support, the voluntary care service, the hands, they've done a marvellous job in the last 6 months, but we don't want to be too in terms of people now being worn out, as you quite say, the voluntary service, as much as we have our own staff. Supporting the NHS, particularly in hospitals, yes, the winter plan and the COVID and flu completed by 31st of the 10th. I'll bring that up in conversation myself, because you'll be present when I present through my report. And in fact, in advance of my report on item 8, I think I'm going to do it after this, which is my conversation that I had last Friday with the chief exec of the Mid Yorkshire Trust, Martin Barclay, because we had a conversation on that one. The step-down facilities commissioned, obviously these are designated settings as well. We've been speaking about this through our committee for quite a while in terms of older people in particular, in terms of step-down provision. And obviously the other issue about this is the staffing that's needed to support them, not only in the step-down facilities, but obviously in the transfer and enablement back into their own home. Sufficient capacity in community-based services. Well, the report in general from the past is now going forward in terms of your capacity again in the community-based services, because it's out there that really in these services they have a great knowledge of their community and their needs, and obviously through the hubs, I'm assuming again that you feed this all through the hubs that are out there to work together. The next part of it here on this page is home first as default position to reinforce review of enablement. Now, I think a lot of us here, and I'm sure yourselves under the pressures that are on the bed capacity in hospitals, have found this most challenging in some homes without the full support packages going in. This is why initially I asked the question on domiciliary care and the packages of care and the staffing that's needed to support them. This sounds dreadful to say it, and do forgive me, but wording means a lot to people. I think the word reinforced sounds something archaic and should be something that is not mentioned in enforcing anything on anybody. I think the default position is actually trying to make sure that the support is there for somebody to go home through the enablement. But I would hate to think that somebody picked up a document and said, well, we're sending you home because reinforcement, you've got to go home. Please take that as a criticism of a word, not the initiative itself. And the next one here is challenges due to the need of discharge quickly to protect the NHS and ensuring safe and timely discharge for individuals. Well, I think we'll have that comment in relation to the latest directive that's gone out to directors of social care about the discharge again from hospitals with positive patients out into the community. And we'll have that discussion around suitable alternative accommodation. I'm moving on, but these are the points that I think are very relative in looking forward. And the changes, as you quite rightly said, from day to day, if not hour to hour. And we've got to have these packages in place on safeguarding. I'll also comment on the pressures on the NHS due to maintaining elective surgeries, as well as the flu COVID winter, because that's in my conversation as well with Martin Barclay. Moving over to the next page, you've got uncertainty about the second surge wave. Well, I think, to be honest, there's no uncertainty about it now. At the time of the report, yes, of course, we're in the high category. And as you said right at the beginning of the introduction, days to come may actually have another impact on our community. And all of this, of course, in terms of the high demand, comes back to the previous 6 months' challenges and capacity, and here we are again in looking to the capacity to respond to increasing demand. The obvious following that up is keeping vulnerable people safe, and Nick and quite a few of us, in terms of the mental health issues that are associated with the virus and keeping vulnerable people safe. There is a challenge out there, I know, in dealing with that, and I have heard of a project, you may know more about it, Nicola and David. I have heard of a project where there's some consideration of people in residential homes that a member of their family, or it may very well be a very, very close friend, could be designated a key worker to actually go in to visit the person in there who feel isolated and lonely and in need of company. And then they would have to be trained in the use of PPE and all the rest of it that goes with it. I think that's one challenge that's worth considering, and to find out if you know anything about it. And if you do, I think as a committee, we'd like to know what it's about. We're in the challenges of staffing capacity and flexibility, and of course then that all depends on the national lockdown, local restrictions, and the community support for the measures. Well, I think we all know in terms of the community support for the measures that if you get mixed messages out in the community and they feel that it's not them but others and they can't understand the messages, then there are going to be difficulties in getting the full support. And where it isn't supported fully by the measures to stop the spread of COVID, one doesn't want to see draconian measures, but at the same time, I think it's incumbent on anybody who is breaking them, either in their own home or in the community, as it says here, should actually be made aware of the dangers of this to themselves and others. And the data availability, the accuracy and timelines, well, I think we've all seen over a period of time some questionable issues around accuracy and timelines, particularly when we saw a data system that had actually lost over 16,000 people somehow. That was reflected and had to be cured. I'll say cured because I think there's a lot of curing that needs to be done. Resilience is in for the long time, and the long time is obviously on the community that you've mentioned in this report. And not only that, importantly as well, and you've mentioned already, is the staffing element within all the services that you support. How well they've worked, and they must be so fearful of another situation where even though the experience of the past has given some lessons for the future, it will have a draining and demanding effect on themselves and their families. Moving on to the next one, in terms of opportunities, yes, it's given more preparation time and a better understanding, improved relationships with partners and building on the co-production report. I'll actually have a comment on that one as well, through a discussion that I had with Martin Barclay on Friday in terms of the improved relationships and obviously technology working for us. We all look at technology when we get onto our Skype or our Zoom and keep our fingers crossed, but obviously it's in this instance, in this type of situation, that technology has actually aided flexible working. And we all know about the whole systems approach and accountability and working across partners. I'm sure that that's something that's been to everybody's advantage. And the risks you've identified here as well, on the mental health of the citizens. We've spoke about that as well, and those living in their care homes. Financial pressures, the medium and long term, that goes back to Olivia's question in terms of funding earlier on, and now we're in the risk of the long-term situation for the funding for the future. The additional demand on hospitals is obviously going to have another issue in terms of the capacity to deal with the COVID situation, as well as those people in the community who are waiting and have been waiting for some capacity for them to go and have maybe elective surgery or whatever. I'll deal with that in the report I've had as well from Martin Barclay. and the longer-term viability of care homes and the care sectors. Well, you've mentioned, Nicola, we've lost 2. I think the sector for a long time has been under a severe pressure. And obviously we've been long awaiting the government to bring forward. I think it's 4 or 5 years now we've been waiting for the paper to deal with the care sector and the care homes. And you've also mentioned the staffing levels across the health and care sectors, fatigue and physical and mental health issues as well. And I have to say that part of it, just my thoughts on it are the staffing in our care homes and people that provide such needed support to older people and those in need. I think it's a shame that in this day and age we have some establishments that are actually working on short-term contracts and at the same time on minimum wage. This is why I asked the question previously on the 461 or 69 hours, because the report that you sent then, Nicola, and other officers involved, it would be useful actually, instead of hours capacity, and sometimes we've got issues here that says staffing, it's so many staff into this unit, so many staff into that unit, so many hours. It would be useful if they were broken down into whole time equivalents, and then we could see actually the average number of staff that I do know they have to have within a care home and a care sector. But, you know, we've all got to take our hats off to all these staff that have been doing so well over the years. The next steps for scrutiny, well, we'll have a look at that one in a moment. And obviously we'll want to work with all of you and hopefully find our ways through the flexibility that you need in terms of support with other partners as well, because we do speak to other partners. I've said my bit on that and I've whizzed through it because I do know we have people who want to ask some questions about the next steps before I bring forward my report from Martin Barclay, which fits in nicely with yours. Sorry if I've run through it, but I think it's important now that having got those points in and recognise the capacity needs, the flexibility need, the financial need, the support that's out there, and you've identified it brilliantly in these reports. I'd like to ask who to ask a question on the way forward and the next steps. Any questions? Any comment? Can you hear me?
I can hear you, Councillor Rhodes.
Can everybody else hear me? Yes?
I can hear you loud and clear.
Yes.
I can hear you too.
Okay. Any questions? Any questions on that 6 months looking forward? Elaine, you want a question?
Thanks, Chair. Sorry I was late in.
No
we're on another meeting.
No problem, dear.
I might have missed it. But when we're talking about there's not enough beds and there's not enough room in the care homes and the hospitals, we had these hospitals commissioned for COVID patients. Why can't we put these people who's got COVID, definitely COVID, in these hospitals? Because nobody can visit them while they're in the hospitals in Wakefield or Dewsbury. And to me, it makes sense then these hospitals can carry on with every other thing that they're supposed to be doing, like the other care. So my question is, why aren't we using them hospitals? Is it because of staff in them or what? And as I say, you might have already told us in the beginning of this meeting.
Thanks, Elaine. Actually, that's part of the discussion I also had with Martin Barclay last Friday, which will be coming up in the report, but I'll answer it now. I asked that very same question in terms of capacity because the situation of the hospital obviously is looking to empty beds and have them for the situation that's going forward. The problem is, you're quite right, Elaine, the problem is staffing. Because if Harrogate, which is our nearest Nightingale hospital, is to open, the expectation is that staff from the trusts around would then have to go to Harrogate to work in the hospitals. which then is depleting the staff that we have within our own Pinderfields, because already within that hospital and other trusts, we've got staff who are themselves isolating because of the COVID. So the staff would be, it's robbing Peter to pay Paul at this particular time. You'll recall when these were built, there was a call out for retired nurses to come back in and help within the service. This call hasn't happened yet. So that's the reason that they can't afford to take any staff. I'm going to speak for Pinderfields, I'm sure others are the same. That's the discussion I had with Martin Barclay. And you can't rob Peter to pay Paul when you're in a situation where beds are needed. And as you say, Elaine, the situation and the patient's need is rising. But that's the discussion I had with Martin Barclay, and thank you for asking that question. And that's the answer. It's the truth of the answer. Robbing Peter to pay Paul to move him up to Harrogate. Now, I see, Olivia, you want a message? You want to have a question?
Sorry, did you say Olivia?
Yes, I did, love.
I think it was wanting more detail about the staffing. I think that to move patients to the Nightingale hospitals is not just moving a number of staff. It's those that have the knowledge to be able to attend to one or two patients who are desperately ill. And therefore, is it at all possible to actually staff a Nightingale and keep our own services going? And I just worry that it's going to get worse before it gets better. That in fact, as the staff become ill, and as more people get COVID, and with the enormous vacancies that existed before all this started, I just think that we're going into a real storm.
Thank you, Olivia. Those are the points that Andy and myself had a discussion with Martin about, and it's the staffing issue. And quite rightly, you say, and I'll repeat, you can't have staff from a hospital that is itself dealing with staffing issues through maybe COVID restrictions themselves, have that staff reduced to open up the Nightingale. It's not logical, and it can't happen like that. So let's hope that somewhere down the line, if there is a need, that somewhere some common sense will prevail, and if there has to be a call to arms again by all those people that came the last time, then somebody's got their head around it to make sure that both areas can be monitored and covered. Otherwise, then the hospitals again are going to be reducing the services through closing theatres and wards, which I'll come to in the from Martin Barclay. Any other question from Olivia, the committee? Any comment? Okay, right. Let's take us on to the extra that you were sent as well on the directive that I mentioned earlier on from the National Health Service, two directors of social care about, again, and the hospitals know about it obviously, about the people being discharged with COVID back into residential homes or within the directive suitable alternative provision. Could David, I don't know if it's you, could you tell us kind of discussions you've had with the hospitals, with in particular our trust, obviously the Mid Yorkshire, about this expectation of suitable alternative provision? And at the moment, what have you targeted? Have you been able to target something? There is a funding pot, I believe, that's going to be eligible for these facilities, but you don't build a facility overnight. And the issue about staffing again. So what's the position, David? Has any of you had any conversations about it?
Yeah, thank you, Chair. There is a separate briefing note which I know you asked for, so I'm hoping that the members have seen that. So that just sets out what we know from the letter that we sent on the 12th of August to all the directors and DPH is Director of Public Health as well. So it isn't necessarily about building new facilities.
Sorry, the 12th of October? You said the 12th of August.
Oh, did I? Sorry, yes, 12th of October.
Right. I didn't want anybody to think it's sat on it that long.
No, I'm going back to the summer. I'm hoping for the summer still.
Yeah, okay.
Yeah, so clearly it's a joint responsibility as well, although the local authorities have to lead on this, but we're working really well with CCG colleagues in particular, because it's generally a commissioning issue in terms of identifying those homes. And Nicola touched on this earlier when she talked about us identifying a home now with 10 beds, so that's being assessed as we speak, so we hope that's going to be agreed. But beyond that, there are a number of homes that have expressed an interest in becoming a designated care home. They will have to go through the same process with CQC to make sure that they are competent and confident and able to meet the latest IPC infection control protocols. So CQC will have to do that, and it's up to them to decide whether or not they are confident and capable or not. So we're having those discussions at the moment. I think there are some issues nationally. I know people are challenging this at certain levels as well, because it is about trying to make sure that people have as fewer moves as possible. So again, Nicola mentioned that ideally people who come out of a care home, go into a hospital and are discharged as COVID positive, could and should go back to their original home, their care home. But if they're not designated as a care setting through CQC, then that won't be allowed to happen. They'll have to go into a specific home, and then after their period of isolation, move back to their original care home. So in terms of good practice, that isn't always a good thing. We're trying to mitigate against that by having a number of care homes that are designated, but we won't know that for probably a couple of weeks or so. The other key issue in there is around swabbing, and members will know this has been an issue for some time now in terms of the timeliness of those swabs before people are discharged, where there's an absolutely clear requirement now for people coming out of hospital have to have had that swab, and if it's positive, clearly that needs to go to the care home that they're going to, so they are aware of their status in terms of COVID. So there are some implications there for other colleagues, particularly health. Of course, we're talking to them about that in terms of what protocols do they put in place to make sure that those swabs are done in a timely manner and are done before people are transferred into care homes. So that will help, I think, in terms of reducing some risks for people in the future as well. And you're right, the funding, the cost of this will come out of the 588 million nationally, which is the discharge fund, which is administered by the CCGs. So the funding for this will come from that pot of money. So I think that's where we are with the designated care settings. There's still work to do in it, and it's, as I said, 12th of October, obviously work in progress. And CQC have quite a challenge, I think, nationally, to get round and make sure that they're assessing homes as quickly as they can. They have capacity, apparently, to deliver up to 500 assessments between now and the end of November. So they will be working flat out to do this, to make sure that we can transfer people.
Right. Can I follow that through, if I may, David, and then I'll ask the committee if they have any other questions. The care homes, in terms of those accepting positive patients in this circumstance, will the care home be something similar in its format interior as we would have, say, a dual registered home, where you can have caring facilities downstairs and you can have medical facilities upstairs? Will there be a definite barrier in the place? Because obviously there'll be some people in those homes, some residents, who are negative, and any transmission then obviously it has to be maintained and protected. What training is there going to be? Other training for staff on a permanent basis? I know your ongoing training. And once somebody is positive in a care home, when is the next test taking place on that person to know if and how long, or if they're positive still, or they've got a negative? And if they've got a negative, is there another test afterwards? How are they measured out in terms of the residents who are placed in these specific places? How is it measured out and tested afterwards? And indeed, not only the residents, but the staff, the testing of the staff. How often is that done? And I know we've been doing testing locally. What is the timescale expected back for the results of these test and trace?
Thank you, Chair. I can certainly have a go at the first few questions in terms of the care homes. I might ask Nicola to help with the questions around testing afterwards if I can. So in terms of making sure that we are, as far as possible, separating people who are positive and negative in care homes, there's already an expectation around that. So the original guidance that came out some time ago is asking for care homes to make sure that they can, and they call it cohorting, so they can separate out and support people who are COVID positive in a way that reduces the risk of that infection spreading through the home. So there's been training delivered on that, so staff are capable of doing that. It is about use of PPE again, and sometimes actually the reason why people can't do that is about the particular layout of their building and their home. So some of the homes we have across Wakefield would find that extremely difficult, and equally some of the residents that people have who have high needs, so people with dementia in particular, it's difficult to isolate and cohort them in a particular home. That's quite challenging, and I think that's part of the thinking behind the government's idea about designated care settings. So the home that we've identified has a separate unit that has 10 beds in there, so that makes it easier to place people who are COVID positive in there with little risk to others that are in there. But equally, when people go home, and we have people living with COVID, who are COVID positive in care homes at the moment, and those procedures and protocols have applied to make sure that they are isolated for that isolation period, and therefore that does protect other residents in there. Some can do that better than others, which is why I think the national call has been, let's make sure that we are providing those facilities that are capable of doing that in a safe way. So the protocols are already there. Some people, it's easier for them to apply than others. I think having a designated setting helps because some of those settings, if they pass the assessment by CQC, will be able to do that better than others. So it just reduces the risk. Nicola, I don't know whether you'll be able to help with the testing side of that?
Before you go off, David, perhaps Lisa or Nicola can help on this one. I did make note of Snidel and the beds there and the process you were going through. Where's the staffing going to come from? Because already concerns about capacity in terms of staff and how you're going to cope. Where's the staff? Have you advertised, or are you advertising for new supposed to stay in the building? So are you advertising new staff these designated areas?
Because the designated areas are controlled by
Lisa, Nicola.
Oh, can you hear me? It's Nicola. I'm trying.
Yes, I can hear you.
Yeah. We have commissioned the beds, so we're paying more than we would normally pay for a bed in that home for the unit. And the expectation is that the care home will manage the staffing, which they seem perfectly happy to do. They are having separate staff for that unit, so there's not the crossover with the other part of the home. So as far as I'm aware, that's perfectly manageable for them.
Okay, thank you, Nicola. As far as you're aware, obviously the discussions will continue, and I'm sure you will have firm written protocols in place that can be followed by everybody. I think more information on how that's going to be done in terms of the security of the staff, if one can have such a thing these days when people get ill. I think we'd need, when you get down to that, Nicola, I think we'd all be pleased to hear what firm protocols you've put down and that they've actually signed up to these protocols in terms of staffing. And not only that, the number of staff that will be needed, because obviously these are going to be 24-hour establishments of need. So it'll be the numbers of staff that will be needed to accommodate the needs of the patients, so residents. So when you get that information, love, and a signed up protocol, it'd be nice to have a look at it, Nicola, just to satisfy our curiosity.
Absolutely. The CQC inspection should be looking at exactly that.
Okay, well, we look forward to hearing or seeing a copy of the protocol. Next, I've got Andy. You wanted to comment, Andy?
Yes, Chair, apologies if you were going to raise this, but in terms of future updates and briefings in relation to scrutiny, it may well be helpful for committee to have a paper regarding the carer situation. Obviously, the increase in responsibilities for unpaid carers has created many more of them, and Carers UK estimate that 4.5 million extra people to care in, and 2.8 of those are during working care commitments. So perhaps committee would be appreciate a further briefing on that. And in terms of staff vacancies, I know Nicola's alluded to this quite a number of occasions, and obviously the recession has only actually increased the number of people that are looking for work. It may well be helpful for the committee to have started the people plan now that's been adopted to the COVID-19 situation.
Indeed, that's helpful, and I'm sure we would to see those figures. And so we're on the agenda, and I've got Lisa next in terms of testing. The timing of when somebody's COVID positive going in, when do they get their next test, and are there tests after that? As far as the staff are concerned, the situation, they were promised testing. I was at a committee in Leeds when the NHS representative announced that unfortunately these weekly tests, it didn't refer to any particular authority, but these weekly tests weren't able to be carried out as intended because of difficulties. So I was glad to hear earlier on that we seem to have a better system in place locally. I know we do that anyway. But can you just tell us deadlines of dates when somebody comes out? When are they tested after coming out into the residential home? What's the time frame for the next test? And both of all these apply to the staff as well, please, Lisa.
Yeah, so everybody is now supposed to be tested before they come out of hospital and to have their COVID result known before they come out of hospital, so that we're clear whether or not they need to go to a COVID positive designated setting or otherwise. Once they've come out of hospital, each care home has a 4-weekly schedule of testing all their residents.
Excuse me, Lisa, excuse me, dear, did you say 28 days?
4-weekly schedule for each of the care homes, yeah.
So the next test is in 28 days?
It might depend on which care home they go into.
No, Lisa. I'm sorry if I haven't made the question plain. It's not a matter of which care home they go into. If somebody goes into whatever, positive,
yeah.
What is it still 28 days to the next test?
Yeah, if they've got a positive result, the latest public health and infection control guidance is that they're not tested for 6 weeks, because you can get a false positive when you're no longer positive because of your body shedding the virus. So if you have a positive, then it's the 10-day isolation period that is critical. In the same way as anyone in the community has 10 days once you've had a positive test. In the care homes, then there's a 28-day testing schedule. So a quarter of the care homes will test week 1, another quarter week 2, the third quarter will test week 3, and the final quarter will test week 4. So depending which care home you're in, it depends on exactly. So if you come out with a negative test, you might be tested. You'll definitely test within 28 days, but it might be sooner depending on the care home you go into and the schedule of their testing. The staff are all tested every week. That's definitely happening in our in-house services, and I know we've been working and a lot take up from the independent sector, so I believe that's the same there. But there's not a test to say you've stopped being positive, because it's difficult to ascertain that, if that helps.
No, let's get some clarity. Let's get some clarity here, because anybody listening into this committee today I think this is the reason sometimes on the instructions and advice that comes out, that clarity and understanding is the main issue. We've got a positive patient being sent to a care home. That person in that care home is then expected, as you've said, within so many days to have shed the virus. That won't be known if that person has shed the virus, because the next test is not going to be for 6 weeks.
So the public health advice is that if somebody has tested positive, that you don't retest them for 6 weeks. If they've got a positive, they will stop being infectious and a risk to others after 10 days, which is why we have a self-isolation period for everybody of 10 days if you are suspected or have a positive test. You can, if you were to be tested on, say, day 11 or day 12, you might still test positive, but it might not actually that you're still infectious. So what they say is to avoid that confusion. We don't retest for a period of time after a positive test. But then you're picked back up after that 6 weeks of not retesting into the usual testing schedule of the care home, whether you're a staff or a resident.
Okay, so we'll just get this clear. So a patient coming out positive,
yeah,
is actually sent to a residential home. In that residential home, all the PPE protections are put in place for that patient and for the staff who are dealing with said patient.
Yeah, and if they're positive, they'll now be sent to one of these designated settings specific for people who are COVID positive to reduce them taking the risk back into other care homes.
That is exactly what we need to know. Now, you've only got 10 beds in Snidel. I'm sorry, where else are you going to get some beds? Are you still looking, did I understand?
Yes, that's correct, Chair. We're still looking, and we talked to a number of care homes, and there are quite a few interested, but as I said, they've got to go through a process with CQC again. So,
okay.
So we hope that we will have more beds, but I couldn't give you a figure at this stage.
Okay. So you did, when the question was asked, David, you did actually suggest that there might be, did I hear you say over 500 that may be available?
500 beds? No,
yes.
No, I haven't put a figure on it because we don't know yet until we've been through that process.
Okay. I heard the figure 500 for something. Do forgive me, there's a bit of tail off sometimes on your mic. So we don't know at this particular time how many beds this is going to be. I think the issue of actually having designated areas is good, but as it says, it does cause disruption and confusion to a lot of older people in the movement structure. And obviously, something's got to be done to prevent infections. And then we've got the staff tested. Is it weekly, Lisa?
Yes, that's right. The staff are tested weekly, and it's typically taking 2 to 3 days for the test results to come back.
Right, okay. 2 to 3 days for him to come back, right. Now, then there's a 6 weeks test. So can I just then come back to the scenario of the person who's gone to your designated area. They've not had a test because the assumption is after 10 days that then that person is in a downward position in terms of being infectious. And right. After 10 days, then that person, maybe 10, maybe more, might be a few days more, is then sent back to their own residential home, or indeed it may be a place in the community. It could be their own home if they're that serious. But anyway, we're speaking about residential because we all saw what happened the last time. So that person then isn't tested for until 6 weeks.
Well, they would be tested as part of the usual care home testing, which is every 4 weeks within that care home. But the recommendation is they're not tested for 6 weeks after they've had a positive test result, because we know they've had that positive test result. We know what their status is. We know what treatment and what isolation they need at that point.
Positive, there's an assumption after 10 days that they're less infectious.
That's right.
Then the next one is 28 days.
It'll be as part of that regular care home testing with that.
Yeah. The next
weekly.
one is 28 days, Lisa. Yes,
Yeah.
part of the regular. So somebody will go in and they will have to wait 28 days to get a test. Now, forgive me going around the houses because I'm going to come to a point here that's very salient to a lot of people. So the test is taken after 28 days. It takes 2 to 3 days to come back. According to the provisions under the public health, if somebody, God forbid, dies after 28 days, I'm sure you're aware that that death is not actually put down as a death caused by COVID. Correct?
I'm afraid I can't answer the detail of that question, I'm afraid. It's not my area of expertise, sorry.
Well, I think that's something we'll go back and have a look at, because that is a scenario that then is something that is of concern to people out there who's looking at the death rates of an accumulation. I understand, and I'll check on it again. I understand that if a person dies after 28 days, that death is not associated with the death of COVID. And I'll leave that one hanging because we will have clarity, and I'd appreciate, David, if you do the same. And now what I would like to do is speak to you again about the designated places. And this is a report again from Martin Barclay, and it's good to are we on a par or equal in good strides on this issue of the designated areas?
Yeah, I think the discussions that we're having at the moment with the care homes is positive. So we have a number of care homes that are interested. We can't say for sure until they've been through that CQC process that will then determine whether or not they are capable of becoming a designated setting and are safe to do that. So once we've had the decision from CQC, then they go on a list as care homes that can receive COVID positive, and then the discharge teams work with that list to make sure that we are discharging people who are COVID positive into those designated settings at that point.
Okay, I understand all that. That's in the briefing note, David, and thank you very much for it. It was well put together. I understand that, and you'll appreciate, I go around to the various joint committees. Well, I don't go around, I use the laptop now. I understand Kirklees are ahead of Wakefield in being able to get this designated areas in place. It might be worth just having a chat to know how they're doing and what they're doing, if it's helpful. You know, we don't need to reinvent the wheel, and I do know about the CQC having to sign them off, but I understand Kirklees are ahead. So just take that as an understanding, and it might be useful for you to think that it's worth considering. I'm here now, and I've got speakers now. I'm going to go these as they're coming up. Gillian, you have a question?
I do, Chair. Excuse me. Thank you. Yeah, I'm going to keep this simple because it is like you say, very, very, very confusing. So, if a patient is discharged from hospital and they can't go home because there is COVID in their home, and they have to go into a care setting, say a care home, upon arriving at the care home, do they have to go into self-isolation in their room, or do they automatically get included into the support bubble? And that's my question, really, because it's going on to what Chair said about, you know, they could test positive later. And then also the other side of it, I would hate to think that they were on their own for no reason. And it is a very, very tricky situation. I appreciate that, but I was just wondering that. Thank you.
Thank you, Councillor Cruz. So just to be clear, are we talking about people who are coming out of hospital who have tested COVID positive at that point?
No, if somebody tests negative, but they have COVID in their house when they went into hospital, so they can't go home. So they go into a care setting because they've got actual COVID in the house and they can't go home. On arriving in that house, in the care setting, the care home, do they have to go into self-isolation in their room, like they kept separate for every, just in case they may be positive later?
The existing protocol says that if people coming out who've tested negative still have to go through that isolation period, whatever might be left on that. So let's say it's 10 days. So they still have to be isolated for that period.
David, you see, this is where there's lots of confusions. Gillian is referring to maybe a senior, a mum or a dad who've been living with the family and they've had to go into hospital for whatever reason. And then when they're discharged from hospital, they're negative, but the family home has suddenly become COVID related. That older person may need, and I think would need, consideration of what to do. The expectation is that somebody can come out, as Gillian says, and actually self-isolate in a home. Go to a room and stay there for 10 days and the family stays away from you, sort of thing. It is a big area. And I think there's more issues around how you work in the community with an elderly person in that stage. And I'm sure our public health and our active social services team, I'd expect them to give the advice as well. I've just had one the same, Gillian, and I've sought advice from the public health, which is the best avenue to go down. So that's what I would suggest to anybody.
Absolutely, and that's what we do as well. So we do on those individual cases, and I accept that a lot of them are quite complicated and not straightforward, which is why you have to look at them individually, I think, and take that advice at that point in time.
Yeah.
And equally, I know that the arrangements that are coming down nationally and locally can never guarantee that we won't have some infections, I'm afraid, and I think we know that. It is about how we reduce the risk to people. And I think by implementing the designated settings, I think we'll reduce that risk for many people, but there will still be risks in the system that we need to continue to monitor and reduce as far as we can through other measures as well.
Indeed. Thank you, David. Thanks, Nick. I know there's some breaking of sound. I keep getting a bit myself. Next question is from Councillor Lynn Whitehouse. Lynn? Can you hear me, Lynn?
Yes, sorry about that. I was searching for my little mouse thing. Right, part of my question has been answered already as regards the testing process. I'm just very concerned about what happens with someone with learning disabilities, and is the criterion different because they aren't able to test them because of the nature of their characters, behaviours, severe autism or whatever it is? How does that equate? Is there any answers? I'd just like to have that made more clear and perhaps put in the papers that we're wanting for the committee, so that we have better understanding of it, really. But I find that they're very, very challenging sort of people that need to be looked after, and also the staff that work with them. If we could have some reassurances on that, because that must be really difficult to isolate them and having to go in hospital, but they can never ever enforce, I don't like that word, tests on them. So there must be something that we can get around for that, because there's a risk of spreading things further.
Lynn, I think that's an excellent comment in terms of the needs of everybody being considered and cared for. And at the next meeting, we've got down safeguarding in terms of the whole issue of safeguarding, and we'll have a discussion with Andy about how we can sort of look at that as part of the safeguarding routine. And I'm sure David and the trust, and obviously for the people that we have that need that kind of support, we'll be going away discussing it. So, Lynn, can we put that one on an agenda to make sure we get the proper details?
If it's helpful, I can also provide a brief update today, Councillor Rhodes.
Well, I'm looking at the time
Okay.
and how we're booked out in terms of Skype. But what you can do, Lisa, which would be very helpful, will you send a briefing to Andy, and Andy will circulate it to all members, and that'll enable us then, when we go to the next committee, to have enough information.
I'll do that, absolutely.
That's wonderful. Thank you very much,
Thanks for that,
Lisa.
Chair.
Olivia, you've made a comment here about the way that the actual deaths are calculated, and unfortunately, as we look at what's happening up and down the country, we can see that's happening. Do you want to add to that comment, Olivia?
No, I mean, I think it's already been highlighted, hasn't it, about the recorded deaths are over 28 days.
Yeah.
And if people die subsequently, that's not added to it. So the worry really is that if you read the articles, it has two figures, doesn't it?
It does. It does. Yes, it does. Now, we've come to the end of the presentation, and I think we've pointed out some of the issues and concerns, and at the same time, it's quite right to actually say to everybody how we express our thanks to all the work that you're doing and your staff. Please pass it on to them. We regularly think about staff in the caring profession every day, because as councillors we do get questions and comments, and some try to clarify some of them, but you know, you can hear today that there are some issues that need to be understood by the community. They really need to be understood. Now, what I would like to do, if you'll bear with me, I've mentioned Martin Barclay's conversation. I'd like to bring that just up here for information, and some of it has been said already. And I think it might be useful for you as well as our committee to hear the points that were raised last Friday. That was Friday the 16th. COVID-19, of course, was the big issue that was spoken about, and how the cases had actually increased an average of 10% daily. And a comparison was made by what's happening now in the numbers now and how they were in April 2020. The intensive care beds were full, partly because there is a lot of other sick patients at the moment. So, of course, the sick patients without the COVID still carry on, and therefore, you know, the intensive care beds are full. So it's all about capacity as well. We were told last Friday that 3 theatres were to close this week to free up capacity again. And those people who were booked in for elective surgery were being sent out letters last week having to, the word that they use now is pause the situation because of the capacity issues. We were told that they were still managing surgery at Pontefract, because, you know, some elective surgery had been put out to Dewsbury and Pontefract, but at the moment they're still managing that. The high dependency unit, the respiratory beds are full, and they had there were 15, but they had COVID-19 patients in there, so they were full as of Friday. The CPAC machines, now all of these abbreviations are great, so I'm going to say the abbreviation is the Continuous Positive Airway Pressure Machines, obviously to help people breathe. There's some contingency to expand with those at the present time. Recognition was made of the pressures on social services as well, and they were closing 2 medical wards this week to free up some more beds at Pinderfields. They have targets to reach in terms of elective surgery, and because of the situation, obviously the target wouldn't have been met, which is understandable because of the situation with beds and the needs for them. And I do also understand the misery that some people waiting to have these elective surgeries, operations, will be in waiting. And because of the waiting and the situation with beds, they won't be able to meet their targets for elective surgery. And the situation that we're in actually dictates how we're trying to accommodate those. There was 100% of outpatient activity in the last 3 weeks, which was good news. And there's 75% of planned activity as opposed to this time last year, so they'd upped the game on that one. The CCG, the Clinical Commissioning Group, are to purchase extra ENT, that's ear, nose and throat capacity. We all know that this was a difficult area before the COVID virus, so the CCG are purchasing more beds to enable some work to be done on the backlog, as well as deal with any cases that are of emergency. And as we go along in the situation we're in, it was recognised that there's an increase in the independent capacity. That's the independent providers out there to be able to help with the bed situation. And it's a case of everybody working together. So those were the issues that I think were relevant and I've mentioned today on the report that you've brought forwards. It's a trying situation, a challenging situation for everybody. We just need clarity and understanding for people out there and encouragement to do the right thing and isolate where need be and do the necessary washing of hands, social distancing, etc. Your presentation today has been really appreciated. I want to thank you all for coming, and hopefully as we go along we'll keep in touch in terms of supporting work through our committee, and indeed look forward to any further reports that can enable us to actually inform the public as well of the great work that you're doing. So with that, I'll close that portion of the presentation and thank you all for your time. We do appreciate it.
Okay, thank you everybody.
Okay, thank you. Now I will then move on in the agenda. That takes us on to item 7, which are the quality accounts. Now, as members will know, these are the accounts of the Mid Yorkshire Trust, the ambulance service, and the mental illness, this SWIMIT, which is the mental illness service. And when it's speaking about accounts, it's the quality accounts of service delivery. Every year these are presented, and unfortunately at a late time. That's the way the system is laid out. We can't change it. This has been a trying year in terms of the challenges that they've all faced, which they have, and indeed we normally have time to appraise and do a lot more. But if you will go to page 37 on your agenda, Andy, you've put in here the statement from the adults in terms of the Mid Yorkshire Hospital Trust and their quality accounts, and then you've taken it over and the other statement is on page 39. Would you like to take us briefly through those two, please, Andy?
Yes, Chair. Obviously, as you've indicated, the timetable is problematic in any event, but because of the COVID-19 situation, it's been more complicated than normal. Obviously, first, the cancellation of our meetings in March and April, which have considered quality accounts, and secondly, the relaxation of the reporting requirements on the NHS providers, which has meant that their publication being delayed in most circumstances. I won't go into any detail in terms of the statements, Chair, because they are self-explanatory, other than to say that because of the limitation in our activities, obviously they are not as detailed as would normally be. Particularly in relation to the South West Yorkshire Partnership Foundation Trust, where the committee's had little involvement this year, other than to say the the suicide prevention strategy, as important as that is. Obviously, next year we're picking up on those issues and obviously making those priorities in terms of the work programme going forward. As I say, the reports are succinct. I know that a lot of authorities in the district have not actually responded this year because of the situation, but because we got some comments to make, I thought it was an important way in which we could actually relay our commentary to the Trust, who, as you know, will have to obviously reproduce our commentary in their quality accounts verbatim. So hopefully it reflects a difficult situation this year, but obviously moving forward we can actually do that in a more constructive and positive way. Mrs Harrison, our quoted member, has submitted a number of comments in relation to the quality accounts, and with your permission, Chair, I will respond to those separately out of the committee because they're not actually relevant to the comments that have been made within the quality accounts. So if that's okay, Chair, I can do that with your approval.
That's fine, Andy. It's been a challenging time for everybody in terms of dealing with things. And I see, Kevin, you've got a comment.
Yeah, thank you, Chair. My comment relates to page 38 and to the third paragraph on page 38. And it's a comment on Andy's rather restrained choice of language there. Final sentence, it was therefore disappointing. Now bear in mind that these quality accounts relate to the period that was essentially pre-COVID. So the performance that we're talking about is not performance that was heavily affected by the COVID situation, which obviously does apply since. Now, the issue of pressure sores is one that we've had somewhere near the top of our list as a committee really for quite some years, and we have had repeated assurances, undertakings, presentations and so forth from the Mid Yorkshire Trust about all the things they were supposedly doing to resolve this issue. And I think, as we know from previous discussion, pressure sores are not simply a matter of patient discomfort, although very massively they are. I mean, pressure sores are a very significant cause of sepsis, and pressure sores are a very major contribution towards people ending up leaving hospital worse than they went in. So I just wanted to say that, as we've said in the report, and I appreciate that Andy uses very courteous language, to say that it was therefore disappointing that the Trust had not achieved, etc., etc., I would personally say was a very, very heavy understatement. I just want to raise a very quickie, a question just lower down. The paragraph that begins, the committee has continued to consider, in line 2 of that paragraph, I've never come across this word decompensation before, so I wonder if somebody could tell me what decompensation actually is. Thank you, Chair.
Thanks, Kevin. Okay, Andy, are you there?
Yes, Chair. Thanks for that, Kevin. Obviously, the language does reflect a degree of not necessarily saying as it is what members want to actually cross it more forcibly. But what I would say is that we've actually, as you say, campaigned on pressure ulcers for quite some time, for the last 5 years to my knowledge. And as the report says, we've called for a zero tolerance of pressure ulcers. But more importantly, perhaps, we've also called for more ambitious targets, because some of the targets were actually reduced year on year, which some cynical might say that it was to actually meet the targets, but obviously it didn't. There are many reasons why pressure ulcers are prevalent, and obviously zero tolerance may not be achievable in the short term, but it's clearly an ambition that we should subscribe to. And I again take the point that you make, Kevin, in terms of the language, but obviously I'm an officer, I want to obviously make sure that not inappropriate. In terms of the other point, decomposition, I think that's deterioration in the.
Can you hear me, Andy?
Oh, sorry, Chair. Should it say decomposition? Was it meant to say decomposition?
Yes, Chair. That's the parlance that's used in the LSUs. I think.
Fair enough. It's all right. As it appears in the report, it says decompensation. Fully understood now. Thanks.
Sorry, Kevin. That's my typo.
Thank you.
All right. Thank you very much. Thank you very much, Andy and Kevin. Now, before we move on to the next report, can I take this opportunity, and forgive me, can I take this opportunity of reminding members that Mrs. Harrison Mavis sent in a list of questions, very, very much the same as we asked here through the meeting. Andy, you've got those list of questions, yeah?
Yes, Chair. Obviously, the majority relate to the previous item in terms of the COVID-19 response.
Yeah.
There are a number in relation to the quality accounts, a number of comments, which in summary relate to pressure sores, which is Mrs. Harrison's personal experience of that, and indeed fall loss prevention, which again, unfortunately, Mrs. Harrison's got personal experience and brings that to the committee. And finally, in relation to mental illness, and as I've indicated, that issue is on the agenda on the 3rd of September. Hopefully, Mrs. Harrison will be in attendance on that day to be able to put those questions directly to officers.
Yeah. So at the moment, Mavis's questions, there were numerous. Mavis pays a lot of attention, as you know, to our reports, bless her, and hopefully she will be able to attend another meeting. It would be useful, Andy, if you could. Are you able to read out the questions so the members can hear them, and then we can get the answers?
Indeed, Chair. The first question in relation to the adult social care COVID-19 response, and that is, do designated settings cater for all ages and gender? Second question is, how long will a patient remain in designated accommodation before being transferred back to the original home from which they came? The third question is, who will monitor the degree of severity of the COVID-19 resident? How many tests will be undertaken? I think we've both covered those points. Will the care workers comprise of fully trained nurses or be care workers from the home who have returned to work in their designated setting? Question regarding full PPE. Question regarding hours of working, which will be timed in such a way as not to become staff don't become too overworked. That's why there's a shortage of PPE. I think that's been addressed, that there isn't necessarily a shortage of PPE. And Mrs. Harrison, being Mrs. Harrison, picks up a number of acronyms. Gender page 26, what is BCS? I think that's voluntary care services. Gender page 27 says D to A, that's discharge to assess. And again, we'll remind colleagues to actually put in full what those acronyms are in future reports. A few comments around mixed messages, which you've picked up on, Chair, and obviously comments around people flouting the rules. That's what I've got in terms of the questions and comments from Mrs. Harrison. Obviously, some of those have been addressed today, but I will forward those on to Lisa and colleagues for them to respond accordingly.
Okay, thank you for that, Andy, and I hope members will agree with us that we will get answers for Mavis from her questions today and make sure that they're sent on to Mavis to satisfy her in terms of her views, as always been respectfully submitted to this committee. Members agree to do that? Take silence as yes. Thank you very much, everybody. That'll take us on nicely now to agenda item number 8, where I've actually got here to October update on the issues that I've been dealing with. Members find it useful. More meetings are coming ahead, obviously. The next one is the 3rd of November. I get briefings from the Mid Yorkshire, from the CCG and the Mid Yorkshire, as I've explained to you. All challenging times, and at the same time, the agenda for all of the trust across all the patches, but particularly in Wakefield, was what they called a reset agenda, and that was trying to reset the systems back to as much normality as they could. But it's still going ahead, but in a lesser format than what had been intended due to the spike again in the COVID situation. We will keep you updated from any briefings from the usual sources, and indeed minutes from meetings that I think are relative to and for your information. So we'll take that as my report for today. That'd be great. Is that all agreed? Thank you, everybody. Item 9 is the Care Quality Commission inspections outcome again. And the following establishments under 5.2 requiring improvement, and then we've got a good for the Dean, Ivy Dean in Ferry Bridge. I think with all that's been going on, when we look at these reports here, it's good that we're having our establishments inspected, and it's also good to hear that they're getting involved and hopefully putting in the necessary measures that are required following these inspections. And that's our report today on those 3 units that need inspections and need a follow-up. We have then item 10, which again is our work programme for 2021. The situation again in terms of the work programme, you will see that they're very much targeted at the issues that we can address at the moment, and at the same time look at the annual report for the year and going forward for the next year in terms of the work programme. We're trying, as you'll see from today's presentation, most of the stuff can take quite a long time because we need to get through the issues. So we're trying to just look at 2 or 3 months ahead until we can get to the annual programme. Of course, if there's anything in the meantime that we feel has to be delved into outside of these issues we've addressed, then that'll have to go on the programme. Or it may be, as we did last year, it may be that because of the issues that are lengthy and in depth, we may have to consider having another meeting to catch up on things. So if you accept this as a way forward, which is the only way we can do things right now, on the understanding of this is our programme, it may be that we will have to inject more time in another meeting, but we'll keep you informed as we go on as to how we're hoping to deal with things, because it's a moving situation. Andy?
Chair, just to obviously indicate that the issue around safeguarding has since been added to the papers that have been circulated with the committee. That was agreed this week with the independent chair.
Yeah.
It's ending on the 3rd. I think it's Lisa that will be accompanying the independent chair as well. And obviously, the taking will take to council with Hepton Stall as well.
Yeah, the safeguarding meeting, yes, that'll be a good item on our agenda. So, looking at our agenda for today then, can we agree that the work programme is as it stands, and we may have to have a moving picture on this one as we go ahead, because that's the challenges and the times that we're in, unfortunately. So that's agreed. I can take through the silence. That takes us on to item 11, which is the forward plan. And as of this one, I don't see that we've got anything identified, which in itself gives us time for a breathe, because we've got to put forward the important issues that's happening at the moment. I suppose we'll be keeping an eye on the next one that comes out.
Just to say, Chair, as well, in terms of the forward plan, which I think is an important point to make, is that whilst there are no items relevant to this committee, obviously there are now wider health implications on other issues within the council. If committee, I know we're obviously push for capacity, but if committee wanted to look at those issues, not directly relevant to this committee, that had a health connotation, then we'll clearly look at them.
Yeah, exactly. Yes, that's how we're going to have to work across various issues, including those that are joint committee related as well, Andy. that's the last item on our agenda today. I hope that you found the presentation today useful in gaining an insight into how our services are to cope and will be for the future few months as we go ahead. Our next meeting, Andy, is the 3rd of December, is that right? Yeah.
Yeah, 3rd of December at 2 o'clock. It will be held remotely by Skype as well.
Yep, 3rd of December, 2 o'clock. So with that, can I thank everybody for their attendance today? And I see, Simon, you were typing a message. Is there? Oh, okay. Thanks, Elaine. And I hope you found it useful and informative. And with that, I'll close the meeting.